You mentioned accountable care organizations, and there are a lot of other related things going on in the guise of payment reform, quality measurement. This idea that healthcare perhaps should move away from fee-based reimbursement to models that pay a little bit differently and tie those to quality measures. And in cardiology, there are a number, I think, that we talked about when I visited with you a couple months ago. I'm curious, I guess, from your perspective, maybe about this idea of payment and payment models, probably specifically in your area of cardiology. If you think this is a good idea, how they've impacted the work that you do, and any potential suggestions you might have for regulators or policymakers.
Yeah. So the biggest thing coming up is MACRA, which is it's instituted now for 2017. And the 2017 year will be audited, and then you'll receive a payment adjustment in 2019. And so it's 19, 20, 21, 22. It's 4%, either neutral or a 4% plus or minus adjustment to your Medicare pay. And then every year thereafter, it's 5, 7, and 9%. And then 9% is where it's going to stop at 2022. But it is still based on, they want to move away from volume, but it is still based on your, if you see a patient for the year, that's your volume. If you see 35,000 patients for the year, that's your volume that's going to determine your payment. So there still is a volume component to it. The more you see, the more you're going to bill, the more you're going to earn. But the adjustment is going to be based on a lot of very, I think, painstaking computer-based quality measures that some you'll enter and some are not necessarily entered at all. Like, for instance, the final, there's quality, there's practice improvement, there's healthcare information advancement, and then there's finally cost. The first three, you as a practice or an individual have to report yourself through mechanisms that they give you. And the cost one, is basically how much it costs for you to deliver care versus your regional peers, and that's not anything you need to report. It's complex. I think it's going to be very complex. It's going to be hard for some practices to comply with the reporting requirements. I've read a bunch on it, and there's not a crystal clear algorithm that they want. There's a lot of vague wording, and as has always been the debate in healthcare, how do you measure quality? Outcomes is the thing that in cardiology we measure when it comes to clinical trials. You can lower someone's cholesterol with a certain drug, but does it result in an outcome, a lower incidence of heart attack, stroke, death, things like that? Taking that from the bedside or the exam table side in the office setting or the procedural setting, and taking that to an outcome is a lot more difficult in the outpatient setting, because there are also other factors at play. I see Mr. Smith for heart failure. I prescribe medications for Mr. Smith. I'm in Amarillo. He lives in a town, maybe Perryton, which is 2.5 hours away. By the time he gets home that night, his pharmacy's closed. He doesn't refill the medicines through the weekend. He celebrates his wife's birthday by going out to dinner, eating some salt, getting admitted for heart failure. Now, the variable of the pharmacy not being open, the variable of something in his social calendar that threw things off, a heart failure admission falls on me as a quality measure. And then how much control did I have over that? Well, very little. Now, I saw him on a Friday, whereas I saw the same patient, his twin brother, on Monday, and he met all the criteria to get his prescription filled. He doesn't have a wife. He takes his medicine. So there's a lot at play that the physician has really no control over. And then there are other, more organized systems, home care, hospice, visiting nursing organizations, outpatient physical therapy and cardiac rehab. You have to really, I think, use all the tools you have outside your office to achieve these outcomes. And of course, Medicare doesn't really give you a huge amount of guidance on doing that, because it'd be difficult for them to do because every community is so different. But in the end, they're going to have an outcome-based approach to measuring your quality, and it's going to fall on it's going to hit your bank account or bonus your bank account. And the thing about MACRA and MIPS, which is what the quality program's called, is that it's a budget neutral. And that's the thing about business and medicine, is that if you take the whole healthcare picture it's a net neutral game. There's only so much money to spend. You can pare it down to how much money is going to be spent in cardiology, in this hospital setting, the outpatient setting, neurosurgery, all the. But when it comes right down to it, that 9% bonus is going to be offset by somebody getting a 9% penalty, so that the net budget at the end of the MIPS calculation is going to be a zero gain. So that's the tricky thing. You want to try to make sure that your practice is going to be competitive, and that you wind up on their CPS score, their comparable performance or comparable performance score on the plus side of the mean, so that you're in the bonus side.
So some of the earlier quality and payment measurement systems, PQRS and others, I had heard stories where the amount of dollars on the table were so small that some practices said, we're just going to forfeit those. But you're talking here, starting at 4% and sort of ratcheting up, either plus or minus. I assume that that's actually pretty significant money for a practice like yours.
It is very significant. PQRS, I think, was a 1% to 2% deal where you got a 2% bonus just by participating. The substance of what you put through the system, I don't really believe was all that. Didn't really portray quality that well, but they just wanted to make sure that you had the gears in place to participate. And I have a feeling it was for a larger program that they had in mind that they've now unveiled. But yeah, when you talk about 9%, just rounded up to 10% of a multi-million-dollar practice, that would be a huge penalty. You don't want to be on the -9 side of that, and someone unfortunately will be. But yeah. But yeah, that does incentivize you to really perform, and at the end of the day, it might not, if we got a 9% bonus, it might not really translate into me putting 9% more in the bank, because it may cost that much to have staff to put the data in, which I guess in the big scheme of the economy, well, there's a few people that are employed now, so payroll goes up.
Right.